Well, good morning, everyone. Want to welcome you all to today's grand rounds here at MHIF. I'm Paul Saraja, a cardiologist, and I have the pleasure of introducing our speaker today, Dr. Nishtha Sodhi. Dr. Sodhi deserves a very warm welcome to MHI and MHIF to be part of the family. She is from the East Coast, but don't hold that against her. We're very friendly in the Midwest. Grew up in Pennsylvania, is that right? In that area, went to college and medical school there, and then did make it to the Midwest, where she did her residency at Cleveland Clinic, and then cardiology at Barnes, and then also did, importantly, a dedicated year in structural heart interventional therapy. And she most recently was recruited to University of Virginia, where she has been the medical director for the structural program and has really helped do a lot of important innovative things, including being a live case operator for some early technologies and also already serving as faculty for many international meetings such as TCT and TVT. So we've been very fortunate to recruit Nishtha to St. Paul. She has not yet bought her winter coat, I just found out, but we'll take her shopping. But it's really just already great to see the imprint that she's already starting to make in St. Paul, and will, I'm sure, make that impression grow only further in the years to come. So she's here to speak about transcatheter valve therapy, and it's a real pleasure to have you. Nishtha, welcome.
Thank you. Thank you so much, Paul, for that very, very kind introduction. It's really, truly a pleasure for me to be here, and thank you very much for the opportunity. It's such a pleasure to be here amongst friends and colleagues. The title of my talk this morning is Transcatheter Therapies for Structural Heart Disease, State of the Art. So this morning, what I thought we would do is take a look at what transcatheter therapy options are for valvular and structural heart disease, take a look at the data, and then take a look at the future directions of this technology. So as you all know, transcatheter therapies have completely transformed and revolutionized the management of structural heart disease. And what I thought we would do today is take a journey through the heart and take a look at transcatheter therapies for valve disease and see what the clinical data is, what the current state of the art is, and go through unique clinical trial examples and unique case examples. So we'll start with the aortic valve. If we go back here, you can see that transcatheter treatment of the aortic valve has evolved tremendously since 1986 when Dr. Alan Cribier performed the first balloon aortic valvuloplasty. Since then, we have had the engineering and development of balloon expanding, self-expanding, and mechanical expanding valves and technology tested throughout these major trials. Today, and as of August of 2019, the FDA expanded the approval of TAVR to low-risk patients with guidelines now focusing on patient age and life expectancy in deciding between TAVR versus SAVR, as demonstrated in the 2020 ACC-AHA update. So I won't show you a standard TAVR case because you all are quite familiar with that, but I believe that the future use of this technology is in unique clinical frontiers and options in patients who otherwise may not have options. And I'll share with you one such case, which is the use of TAVR in an LVAD patient. This was a 48-year-old female with peripartum cardiomyopathy, status post HeartMate 2 as a bridge to transplant. Her EF was known to be about 10% with moderate to severe aortic insufficiency and a biventricular ICD. And she was actually actively listed on the transplant list as status 1A with a blood type O and a very reactive cytoscreen. So she was very patiently waiting. In the interim, she presented to the hospital in florid cardiogenic shock with elevated lactate, renal failure, and liver failure. And despite our heart failure team's best efforts in changing around her pump speed on her LVAD and changing around medical management, she remained in cardiogenic shock. This was her TE, and you can see she just has profound severe aortic insufficiency with all of that blood pumping getting sucked into the LVAD pump, getting dumped into the ascending aorta, and then getting sucked right back in. So effectively, she had no systemic forward flow for any sort of body perfusion. We did a very robust heart team discussion with multiple disciplines involved, and ultimately the decision was to pursue a TAVR in this patient in shock with an LVAD and aortic insufficiency. So we normally love to get Joao and our imaging partners lovely three-mensio reconstructions to tell us exactly what to do, what angle to use. And of course, in this unstable patient in renal failure, we would not have been able to get her CT. She just was not stable to go down. So here what we're doing is TE sizing, and you can see a variety of measurements being made. With the idea, the question that we had to tackle was, are we going to use a balloon expanding or self-expanding valve, and what size are we going to use in order to ensure that this valve anchors into this annulus? As you guys may recall, this is a young patient with a regurgitant process, so a very different situation and scenario than the elderly calcific valve that we have something to anchor onto. So the decision was made to oversize and pick an oversized valve with a self-expanding valve, with the idea that we did not know how this new valve was going to interact with the LVAD, and that we would want to have the opportunity to reposition should we need to. So this is our first picture here, and you can see again, no real calcium to help us demarcate the annulus, and so we have two pigtails here to help us delineate that. And this is sort of our first attempt, and you can see that although we had the LVAD RPMs turned down a little bit low to help stabilize what we thought would be a good idea, you can see that even despite that, the valve is being sucked in by the LVAD pump. And so the valve has essentially got sucked in and migrated distally. And you can see here that on echo as well. So this is just not a good position at all for us to take this valve. In the interim, in just the few moments that we had turned down her RPM, she decompensated pretty quickly. And so we realized that we were going to have to do this with her full RPM speed at 9,500. And this is now our third attempt at positioning. And we're sort of liking this much more than our first and second attempts. And then upon deployment, holding our breath to ensure and hoping that nothing migrates distally. And thankfully the valve stayed, and she did great. Ultimately discharged and back to work. Now, we have thus far used the TAVR valves that are available to us in sort of off-label fashion for aortic insufficiency. But now as we enter the era of truly dedicated transcatheter technology for aortic regurgitation, we now have the Yenna valve. And in 2021, the Yenna valve received CE mark approval, becoming the first on-label TAVR system for aortic insufficiency, and currently is commercially available in Europe. Just a few weeks ago, the German center that performed the first 58 consecutive patients published their real-world results at 30 days. And as you can see here, among these 58 patients who underwent the Yenna valve procedure, 0% had moderate or severe PVL at 30 days. Most patients remained in NYHA class 1 and 2. And we're actually fortunate to be part of one of the US sites enrolling in the Align-AR trial, now looking in the United States at aortic insufficiency patients that are at high surgical risk in this trial here. So where do we stand in 2023 with TAVR? It's almost the default frontline therapy, remarkably so in just the 21 years that the first TAVR was performed. And we're almost looking for reasons not to pursue TAVR anymore and instead looking at surgery. So the future of this technology, I feel, is in situations where we need to think outside the box, such as in that LVAD case I showed you, for aortic insufficiency patients, as the Align-AR trial will demonstrate, and in the lifetime management of these aortic valve patients. So we'll now sort of pivot and move to the mitral valve. And as you all know, mitral regurgitation is one of the most common valvular heart diseases, with a prevalence of nearly 10% in individuals greater than 75 years of age. This is the Cleveland Clinic study performed by Sachin and colleagues. And in this study, on the outcomes of heart failure patients with severe MR, you can see that 84% of patients with degenerative MR were offered surgery and operated on, but only 36% of patients with functional MR were offered and operated on with surgery. And as you can see here, those patients, regardless of primary or secondary MR, that did not receive operation had much worse outcome in terms of both mortality and in terms of heart failure hospitalization. So there's a huge population of both primary degenerative and secondary functional MR patients who can benefit from transcatheter therapies. So what are these transcatheter therapies for the mitral valve? We'll talk about bioprosthetic mitral valve dysfunction and the valve-in-valve procedure, and then take a look at native valve leaflet repair and native valve replacement. So the valve-in-valve technology was approved in 2017 for use of the Edwards sapien valve for high surgical risk patients. And this is a procedure familiar to all of you guys with transfemoral venous access coming up and across the septum, performing a balloon septostomy across the septum to then ultimately bring up the Edwards delivery system for the valve inside the prior surgical mitral valve. We'll take a look now at the state-of-the-art of transcatheter mitral leaflet repair. And here, the concept is of transcatheter edge-to-edge repair technology. The concept behind this really stems from the surgical stitch that Dr. Alfieri pioneered to create a double orifice valve. And our story really begins with the Everest trial. 279 patients with 3 to 4 plus MR were randomized to MitraClip or surgical mitral valve repair. Compared with mitral valve surgery, the MitraClip arm was substantially safer, but not as effective in reducing MR and LV remodeling. Nevertheless, with follow-up at 4 years, NYHA functional class and overall survival were similar in both groups. And this is what led in 2013 to the FDA approval of MitraClip for primary degenerative patients that are high surgical risk. We are now looking at this technology utilization in intermediate surgical risk, and we're fortunate to be a site for the Repair MR trial, which is also actively enrolling here at Allina. Now, the same question of whether transcatheter edge-to-edge repair could be utilized in degenerative MR patients was then subsequently applied to secondary MR patients and functional MR patients, and this was the basis for the COAP trial. Patients were randomized 1-to-1 MitraClip and GDMT versus GDMT alone. And the number needed to treat to prevent 1 hospitalization for heart failure within 24 months was found to be 3. The number needed to treat to save 1 life within 24 months was 6. And so this was a very landmark trial and led to the FDA approval for MitraClip for functional MR patients in March of 2019. Now, the procedure is sort of well described and documented about how do we do this in stable FMR patients. And in fact, the 2022 guidelines have been updated to include MitraClip into the guideline strategy. And we're now actually trying to push the frontier of this technology even in acute heart failure patients and even in the shock setting. Now, when we talk about functional MR, there is also an emerging subset of secondary MR called atrial secondary MR, where patients have normal LV function, abnormal left atrial size and function, atrial fibrillation, and Carpentier type 1 normal leaflet function. And although COAP looked at significant benefit of TEER in ventricular FMR patients, it had not included those patients with atrial FMR. So I had the opportunity as part of the Global Expand investigators to look at TEER in this patient population. Global Expand had 1,041 patients enrolled, of which 413 patients had secondary atrial FMR, and we then categorized those patients with ventricular FMR and those with atrial FMR. And the definition that we utilized to define atrial FMR was those patients that had LVEF of 45% or higher, no wall motion abnormality, history of atrial fibrillation, and then any one of these parameters of left atrial size dilation, whether that was from a volume index, a diameter index, area index, or a mitral annular systolic AP diameter measurement. We then found 53 of those patients and compared them essentially to the ventricular FMR patients. And you can see here in regards to MR reduction was that patients with atrial functional MR had significant reduction in MR at 30 days and 1 year compared to baseline. And as you can see, 94% had less than or equal to 1 plus MR at 1 year, which is comparable to ventricular FMR patients. This MR reduction translated importantly into clinical improvements, as you can see here with NYHA class. Atrial FMR patients demonstrated improvement in NYHA class. At baseline, you see 85% in NYHA class 3, or greater, and at 1 year post-procedure, 79% of patients in NYHA class 2 or lower, and very similar to the right-hand side of the screen of what is demonstrated in ventricular FMR patients. This also translated into quality of life improvement as measured by KCCQ scores, significant in atrial FMR patients to nearly the top quartile, again, similar to ventricular FMR patients. And you can see here when we look at heart failure hospitalization at 1 year, as well as all-cause mortality at 1 year, both cohorts demonstrated significant improvement. And thus, I would say two things. One is the recognition of these patients. They have unique echo findings, classically with a restricted posterior leaflet and in riding anterior leaflet override, not to be confused or misinterpreted as degenerative mitral valve disease with a prolapse of the anterior leaflet. So one is the echo finding of this, but then recognizing that these patients do benefit from TEER, of course, along with the cornerstone of GDMT and the restoration potentially to normal sinus rhythm. As part of Global Expand, the other initiated project that I had the opportunity to work on was to take a look at gender. And the reason that this sort of came to my mind was because we know in the surgical literature that there are significant gender-related differences in mitral valve pathology, clinical presentation, and even rates of referral for cardiac surgery. Women are generally older. They tend to have more mitral annular calcification at the time of their surgical intervention. Women have generally have been found to have higher preoperative risk and are more likely to actually undergo surgical mitral valve replacement over surgical repair and have impaired survival and long-term outcomes. So I had the question, does that exist with TEER therapy? So we were lucky to have this proposal accepted to look at differences between men and women undergoing TEER in the Global Expand study. Again, 1,041 patients were enrolled in the study, and this is one of the few MitraClip studies that have nearly equal representation between men and women, 470 women and 571 men. And the outcomes that we chose to look at were MR severity, functional capacity, quality of life, all-cause mortality, and heart failure hospitalizations, and 30-day major adverse events. When we take a look at the baseline characteristics between men and women, you can see that women were older. They predominantly had etiology of primary degenerative MR over secondary functional MR. When we take a look at all of the comorbidities, they tended to actually have fewer incidents of comorbidities compared to men. They tended to have preserved LV function with normal LV size and smaller LV sizes and dimensions. When we take a look at index procedural outcomes, although women often had slightly lower implant rates and acute device success, women and men equally had acute procedural success. Men did tend to have a higher combination of both device usage, both the XTR and the NTR deployed, while women tended to have predominantly NTR-only devices deployed. And when we take a look at the clinical outcomes, you can see both men and women had experienced a statistically significant reduction in MR, which is durable and sustained through 1 year. Here again, heart failure hospitalization and all-cause mortality between both men and women, equally good and sustained through 1 year. And that also, of course, translates into NYHA functional class and KCCQ score, which were improved in both cohorts and sustained and durable through 1 year. 30-day major adverse events between both groups undergoing TEER were very comparable between women and men. And so this data helps us to understand that despite being older and having similar STS repair and replacement scores, women experienced acute procedural success with significant MR reduction after MitraClip, leading to substantial NYHA functional CAS, KCCQ score improvement, all sustained out to 1 year, just as the cohort of men did. The rate of 1 year heart failure hospitalization and all-cause mortality, along with 30-day major adverse events, were consistent between both men and women. And this is truly, as I mentioned, one of the first MitraClip studies to have comparable gender representation in men and women across primary degenerative or secondary functional MR patients. And so as we're screening these patients, if they meet echo criteria regardless of gender, they should be referred and at least considered for TEER technology. So now what about the future frontier of transcatheter edge-to-edge leaflet repair? We talked about TAVR in an LVAD patient, and now we'll talk about utilizing TEER in an LVAD explant patient. So this was a 32-year-old female. She initially had presented in cardiogenic shock with biventricular failure and ultimately received a Heartware HVAD. She actually dramatically improved at the 1-year mark to the point where she was being considered for LVAD explant. And during this explant workup, her RPMs were turned down low as she was getting to her echo, and that's when severe MR was unmasked. And so the question became, what do we do about this? Is she going to struggle if she goes to get her LVAD explanted, and is she going to go into acute severe MR and have a hemodynamic compromise? So as a heart team, we decided to do a prophylactic MitraClip with her LVAD in place. We implanted 1 NTW at A2P2 and largely guided by the RPMs of her LVAD during our case being turned down quite low to understand where exactly the regurgitant jet was coming from. And after that, the following day, she went to the OR for LVAD explant and actually did remarkably well to the point where she was able to come off of the heart transplant list. So now what about TAVR for the quote-unquote mitral valve, or the equivalent of that? At ACC last year, we celebrated the 20-year anniversary of the first TAVR being performed, and we're now 20 plus years, and we still sort of don't have that equivalent, so to speak, replacement strategy on the mitral side. The reality is that the mitral valve is a very different beast and entity than the aortic valve. In AS, we have a fixed valvular pathology leading to pressure hypertrophy, whereas in functional MR, there's an interaction of the mitral valve and the left ventricle leading to volume hypertrophy. When we take a look at additional considerations, we know that the mitral valve is asymmetric and D-shaped. There's annular and leaflet remodeling. There's generally lack of a well-defined rigid annulus for anchoring, unless we're dealing with, of course, calcific disease. There's a complex subvalvular apparatus with chordae and papillary muscles. And then, of course, there's a dynamic relationship between the LV and the mitral valve throughout the cardiac cycle. And of course, if that wasn't enough, all of these considerations combined with the LV outflow tract and the aortic valve is also quite important. So for all of these reasons and more, we still in 2023 don't have sort of a commercial TAVR valve of the mitral, a TMVR of the mitral. On top of that, another key difference between the aortic and mitral valve replacement is the anesthetic considerations during the case itself. Oftentimes, mitral patients have concomitant LV dysfunction and decompensation, and so they can have acute hemodynamic compromise during the case, which is very different than our TAVRs, which are now, for the most part, being performed minimalist and with conscious sedation. So working with anesthesia and our colleagues on that end is very important during these cases as well. So this is a case of Tendyne TMVR, and I first point out this echo to demonstrate just how severely degenerative it was in regards to the MAC. There's a posterior leaflet ledge of calcium with a spicule, and the starting mean mitral gradient was found to be 5. And so this patient was clearly not a candidate for undergoing leaflet edge-to-edge repair like we talked about, and truly needed a dedicated mitral valve replacement strategy. So our plan was to prepare the annulus by doing a transeptal valvuloplasty with the Inouye balloon in order to then do the transapical TMVR. And just like in coronary lesions, where if there's high calcific burden, we prepare the lesion, so too did we do this for the valve. We prepared the valve in order to then better seat the TMVR valve. You can see here transapical access is obtained, and we are deploying the Tendyne valve. The A2 proud cuff is being shown here, and then ultimately the valve being deployed. And we had the opportunity to do this back in 2020. I believe our fearless leader, Paul, may have even been on the moderating us virtually as we did this live case back in 2020 for TCT. This is another transapical platform with the Medtronic Intrepid valve, and kind of very similar concept after getting transapical access and utilizing echo then to deploy the valve. Now, when we look at these cases, it's almost as if we're driving a harpoon into the apex of the heart. And so I always sort of say, is this is really percutaneous and it's not, right? This is very reminiscent of our transapical TAVR days. And so what I think is going to be the future, of course, is the game changer of transfemoral venous transseptal platforms. There are a few out there. This is a case that we did with the Edwards Evoke system, and we're actively enrolling here, fortunate to have several different platforms. And so the future is yet to come, the story of TMVR kind of yet to come, trying to figure out which platform to utilize in which cases and which anatomy. And so this is kind of an exciting time for TMVR. So we'll now pivot to the tricuspid valve. And this was long considered the forgotten valve, but no longer. And again, when we take a look at options for the tricuspid valve, we can target valve-in-valve strategies and then take a look at native leaflet repair, native annular repair, and native valve replacement as well. So this was a 68-year-old female who had prior Epstein's anomaly, who initially had surgery with a 33 mosaic, and several years later came in. And here we're doing a valve-in-valve tricuspid, very similar to on the mitral side, where we come up with the Edwards system and deploy that sapien valve inside the prior surgical valve. Now we have transcatheter tricuspid leaflet repair, and of course, congrats to Dr. Saraja and the team here for really sort of tremendous contributions to TriLuminate and all the results and data that was presented earlier this year at ACC. So this case is all sort of well familiar to you all in regards to edge-to-edge repair on the tricuspid side and the procedural strategy when we look at edge-to-edge repair for tricuspid. Now, when we shift and take a look at annular reduction, CardioBand is another device being investigated here. And the idea behind CardioBand is to try and reduce the tricuspid annulus by individually placing anchors around the annulus. The case is performed with TE as well as ICE imaging, utilizing multiplane to really understand where to place the anchors to avoid leaflet impingement. And this is sort of one of our cases here where we placed 17 anchors, which all need to be individually placed. And once all the anchors are placed, there is a cable that connects each anchor, and we basically apply pressure using a size adjustment tool to essentially help cinch and reduce the annulus size. And over time, the idea is that by reducing the annular dimensions, the TR improves. Now, what about TAVR for the tricuspid valve? What is the state of TTVR? So as we talked about on the mitral side with significant challenges, on the tricuspid side, we also have challenges to why in 2023 we don't have a dedicated commercial TTVR. One, of course, challenge is that the tricuspid valve and annulus is often very large and dilated, requiring a large valve and consequently a large caliber delivery sheath. The tricuspid valve is not generally calcified, making anchoring an issue as well. And there's potential interaction of a new valve with the bundle of His and the conduction system. And if a pacemaker lead is present, interaction with that as well. There's potential increase for RV afterload. And if all of that wasn't enough, imaging of the tricuspid valve is often one of our biggest challenges as well. So one of the platforms that's being studied and investigated is CardioValve. We had the opportunity to work with the R&D team over in Tel Aviv. And another platform being the Edwards Evoke tricuspid valve, which probably at this point has the most sort of clinical early experience. Here you can see severe TR in the presence of a pacemaker lead. And the idea behind deploying this valve is to ensure that each anchor of the Evoke valve is capturing leaflet appropriately and that the directionality of deployment is centered across the annulus. You can see here the valve is fully deployed, and you can even see the pacemaker lead at around 12 o'clock on the short axis view there. When we put color, you can see there's no central regurgitation through the tricuspid valve of the Evoke, and really just trivial, mild paravalvular where that patient's pacemaker lead is present. And we had the opportunity to do this as our first Evoke case back in 2020. The TriScend study looking at utilization of the Evoke Edwards valve is currently underway. And in the advent of all of these transcatheter therapies, several questions arise. One is understanding patient symptomatology histology truly from tricuspid valve disease, isolated tricuspid valve disease, as well as understanding the echo gradation of severity, and then understanding what should our outcomes in these clinical trials be. Should they be the hard and fast mortality, or should they be quality of life outcomes and endpoints? And I had the opportunity to be part of the Tricuspid Valve Academic Research Consortium, and in TVARC, we're essentially trying to answer those very questions as the technology on the tricuspid side is evolving. So this morning we've been through a whirlwind of valve disease and tools. I think the important part of this too, and what I'll spend the last sort of 10 minutes talking about, is how do we balance these very expensive toys with the reality of the healthcare system and healthcare economics and metrics that we all work in. And when we look at procedural quality, economics, and optimization, we all know about the contribution margin equation, which of course looks at revenue and then fixed and variable costs. We'll use this example and kind of delve in further, looking at margins, and we'll kind of talk about revenue and cost. And we can use TAVR as an example to apply to this business model, since TAVR, of course, is the longest commercially available transcatheter therapy. So when we start to take a look at revenue, that price or reimbursement price is the money that the hospital receives for any procedure, for a given procedure. And the reimbursement rate per TAVR depends upon a variety of things. One being payer type, whether that's Medicare, private insurance, or private pay. It also depends on geographic location, whether there's a training program at the institution performing the procedure, and then the TAVR volume at that institution itself. Currently, 90% of TAVRs in the United States are being reimbursed through Medicare, and the literature indicates that the average payment to a hospital of a patient undergoing TAVR is anywhere between $23,000 to about $69,000, plus minus some change, depending upon all of those factors that I just mentioned. When we take a look at the other component of revenue, that is volume, and that is volume of cases. And that over time is expected to increase now that the low-risk trial is well approved since 2019, and as new centers begin to continue to pop up that are doing TAVR. Now we'll talk about the other side of this equation, which is cost. And clearly there are many components of this. The first of being the material. And the material in this scenario is referring to the cost of the TAVR valve itself. And in the United States, at this point, we have few companies that are producing the commercial valve, and as such, the cost of the valve is high. And when we look at overhead, that overhead is referring to all of the personnel and all of the equipment required to perform the procedure. As we've shifted away from general anesthesia, TE, and ICU monitoring, we can show that when we adopt minimalist TAVR, we can, on average, as the 3M study showed, save about $10,000 per case by doing minimalist TAVR and shifting away from all of the resources that were previously utilized. The length of stay was initially for TAVR anywhere from 5 to 7 days, with now the national median length of stay being 1 to 2 days now. Labor refers to the personnel required, and as I mentioned, we've now shifted away from general anesthesia, ICU, TE, and so that minimalist strategy has really affected that component, and then complications, which of course we're constantly involving our techniques and such. So in the next 10 years, this is based on the predictions that Dr. Chet Rahal and Kumar over at Mayo performed for TAVR business analysis. They suggested that over the next 10 years, the reimbursement price of TAVR is expected to continue to decline, and we're already seeing that with CMS changes. They predict that the volume of TAVRs will continue to increase, and as I mentioned, that is due to the low-risk patients being adopted with TAVR and new centers and sites being opened up. So when we take a look and try to utilize the Porter's 5 forces of business analysis to understand where is TAVR going in the next 10 years, we really have not very much wiggle room to really try to improve our contribution margins. There's really sort of not much here that we can sort of change to really sway the contribution margins in looking at this equation. So that's why I think really focusing on the other aspect of structural heart disease in terms of building an appropriately financially viable and stable and efficient program is important in order to really have as much control of the contribution margins as possible. That involves procedural optimization with most centers now, or I shouldn't say most, but large amount of centers that are doing high volume have really adopted the 3M minimalist pathway without use of routine general anesthesia, TE, or ICU. That also focuses on operational optimization and workflow. And with the shift towards nurse-led sedation, that has dramatically changed the workflow, the number of cases that can be done in any given day within a team in a room. When we look at other strategies, we talked a lot about everything I've said this far has been sort of the in your face, in the procedure room, things that we can control. But another very important piece is the behind the scenes of what goes on with billing and coding. For TAVR, there are 2 DRG bundles depending upon the presence of major comorbidities and complications. And documentation is so critical to allow the billing and coding folks to appropriately document and bill in order to ensure that the reimbursement is appropriately being received for the hospital and the program, as there's a dramatic difference in the reimbursement price between both DRGs. Of course, the next part of really outreach, contracting, and growth is, of course, everything that we know in terms of going out, shaking hands, and really kind of adopting that hub and spoke model to increase patient volume and throughput, whether that's on the clinical trial front or commercially. And of course, as we all know, that includes utilizing strategies of smart social media, online presence, as well as any of the contracting that we can do on the hospital end for group purchasing and for bulk contracting to ensure that that valve price comes lower. So we have gone through a lot of different tools as well as a lot of different strategies and thought process for structural heart and how we grow programs. And this toolbox is kind of ever expanding. And even this morning, we didn't even begin to touch on interventional heart failure and the transcatheter junction for that. But this toolbox is ever expanding. And I always say, and you know, when we had fellows rotate with us, I always kind of say, the first and foremost thing is to not just do a procedure for the sake of doing a procedure. It's really to understand, get to know your patient and their family, and communicate with the primary cardiologist, the PCP, any of the staff APPs that may have been involved to really understand, are we going to make a difference and help this person with this procedure, or should we continue medical therapy and think of other options? And so I always say, don't be that proceduralist, just do a case. Really, really, champion and advocate for your patients, because it's not just about a case, it's about making sure that your patient benefits and has improvement in their quality of life. And with that, I'd like to give a special thanks to many people here, many of whom are in the room and plugged in online, and just wanted to thank you all for this opportunity. It's a very exciting time, and I'm truly privileged to be part of the team. Thank you very much.
I don't have my microphone anymore, but
we've got the audience mics on.
Perfect. Fantastic.
Thank you
you so much. So I'm sure there are 1,000 questions that we would have for you. Anybody from the audience have any questions for Nishtha? John?
Sure. Well, thank you very much.
Sure.
It's wonderful that you're here. One other thing about costs that you talk about are opportunity costs. And that is what an administrator looks at and thinks, oh my gosh, you're going to spend all this money and take away my surgical aortic valves. And I think Paul has shown that there's just a huge lack of awareness of the need for the therapy at all, and that there's a lot of room and it actually grows surgical outcome. How do you deal with you going to a new site, having to deal with new folks who are not as used to this?
Sure.
And then you have to build from the bottom.
Funny you should ask that question. So I think the halo effect that you described is very real, and that translates, of course, into increased surgical valve procedures, increased imaging. The whole service line benefits, really the whole hospital benefits by introducing a new technology into the system. I think that there needs to be, let me back up a step. I think for any program to be successful, it can't be from one person or individual. And so it's so critically important that before any initiative be started, to have that open dialogue and conversation with partners that are not just interventionalists, but across all spectrums of cardiology, anesthesiologists, and also equally important with hospital administration, because there is an upfront investment that needs to be put in order to get that return on investment from a structural heart program. And so without having that upfront buy-in from everyone, both financially and from a mission standpoint, being able to see all the benefits of what this translates over service lines is not going to happen. And really, I found that in order for any program to be successful, you have to have all sort of hands in. One person is not going to be able to grow and build this. And I think when everyone's on that same page, you do see the rises in volumes across the board that you were describing.
It's a fantastic talk and overview, and glad to have you with us as well. I was thinking if you could articulate a little bit more about, the post-procedural care, and in trying to also go into the economic perspective, what are the opportunities that we have to reduce readmission rates from prehab, from the pre-procedure to the post-procedural care? What are the things that other centers are doing that we could potentially also utilize?
Yeah, that's a great question. So one thing that we adopted at UVA was a prehab program where we tried to identify patients that were frail or that were going to be discharged to some sort of SNF or facility post-valve. And as you know, that sometimes waiting for discharge to get placement oftentimes drives up the length of stay from that perspective. So we tried to identify patients that were good prehab cardiac rehab patients, developed a whole protocol, and when we saw them in the initial TAVR consults, actually consulted, so to speak, with our PT folks, and they went to outpatient rehab even before their valve procedure. And so we already had an assessment and understanding from our physical therapists of, hey, this person is likely going to need SNF, or hey, this person we think we can get to home with home PT. So that was one area in regards to length of stay. I think the other is understanding what resources are available, and each center is a little bit different. I think we've predominantly shifted altogether away from general anesthesia and TEs and everyone going to the ICU. And so really trying to utilize as much minimalist while being still safe and ensuring 100% outcome for the patients is important. And each hospital, I think, depending upon their resources and personnel, is going to have that look a little bit different. Whether that's recovering in a sort of post-procedure area and then going home, or whether that's recovering in the post-procedure and then staying the night and going home the next day. I think we still are fine-tuning that, and one of the ways that I think we can do that too is conduction. I think is a big thing that we think about, and also in terms of that, I try to identify high-risk conduction patients, those that already have a baseline right bundle branch block and some AFib or something. We try to get the monitors prehand, beforehand, or at least get them to meet the electrical folks to know. But things like that, I think it sort of can be tailored very much to what resources you have and sort of what the patient looks like.
You want to talk a little bit about same-day discharge for TAVR and the economics of that?
Sure.
Well, I mean, I guess I think, historically, we've been trying to do same-day PCI for decades.
Yeah.
It hasn't really quite created or had the penetrance we wanted. But now there's a lot of talk about doing same-day TAVR, and it seems to me there's a little bit of a leap there, but I would love to hear your perspective on that.
Sure. I think a little bit of a leap is the right way to describe it. I think that for, I think somebody that has no conduction disease, transfemoral access, first case of the day, I think some individual operators and institutions are suggesting that those patients can go home that same day. I think what we all struggle with as a community in structural is worrying about the patient and their conduction system or any sort of complication that may arise within the first 24 hours leading to readmission, Joelle, like you mentioned. And I think it's going to take a lot of work out of high volume centers, whether that's abroad in Canada or within the United States, that are doing that consistently to really look at if we can adopt this for more patients. Because I think that programs that only have an N of 30 or 40 or 50, that volume and number of patients is just too small to sort of translate that and utilize that for all patients. I think that some of the data of the groups that are doing this, though, have suggested that in looking at the patients that do go home the same day, those patients, interestingly enough, thus far, again, small sample size, haven't had recurrence of readmission, and the rate of having conduction issues requiring pacemaker has been pretty low. Having said that, though, I mean, 30 to 40 patients is too small for us to translate this into sort of a mainstream practice.
Still early in the
Yeah.
experience. Yeah. Other questions?
We do have a virtual question from Dr. Hauser. He is asking if you could please comment on expandable versus non-expandable TAVR and if you have a preference between the two.
Sure. So the self-expanding valve is the Medtronic Court valve, and right now the other sort of main option that's commercially available is the balloon expanding Edwards valve. And I always say, every time anybody asks me which one's better, I think what I always say is use the CT. You have to understand the patient's anatomy. What did their vasculature look like? What does their annulus look like? What does their LVOT look like? Well, what is the, all of the measurements we do, sinus of Valsalva, coronary height, because all of that is different for each patient and really influences which valve I use, because in certain patients with certain anatomy, one valve may be safer, one valve may not be as safe. And then in other patients, maybe, both could be equally good. I think that over the next year or two, we're also going to be getting longer term data of both valves and what the effective orifice area size is for patients. And I think that will help influence some decisions as well. But for the short term, in terms of what we got right now, I always tell fellows this too. Before you enter a case, you should own your CT and know what you're walking into, because oftentimes you can predict complications, prepare your staff, prepare yourself, and use that to help do a better case for your patients. Because like I said, it's not just about going up with a valve and putting in a valve and going home. If we really want to do quality structural heart, and you all know this, it's really, really doing justice for the patient and making sure that you as the operator have done everything from a procedural standpoint to make sure that they achieve that best procedural outcome. Because we are looking at lifetime management of patients. You were just talking about a case earlier as well. These patients are living longer, and we need to do the right thing by them. And oftentimes that begins in the initial consult when you're first meeting the patient for the first time, asking them, what do they want out of this? What are their symptoms? What are their goals? What do they want to get back to? And so that journey is why I love structural heart, and I think that journey it's really our responsibility as operators to make sure we're doing right by them.
How much do you read your own CTs and your communication with the people who officially read it?
I can
How does that work?
So I was fortunate at WashU where I trained on Thurmencio. I do every single one of my Thurmencio reconstructions before every case. I am happy to collaborate and look at, especially if we have a Joao, now that I look at their report and I say, wow, this is great, or consistent. Before, where in my prior institution, mostly it was read by radiology, and I'll be honest, I never looked at the reports. I just did my own reconstructions, and that's I really feel like as an operator, you need to be able to do that. If you are relying on vendors to tell you what valve side and what access to use, I just think that's a disservice to the patient.
I was going to answer that. She's basically the only interventionalist in this area that does it on her own. So it's skill to do so. Any more online questions?
No.
Yeah, awesome.
Thank you for very interesting great lecture. Regarding like the mitral regurgitation, I have a question. Since there is many kind of the equipment that available right now, especially the mitral clip and the mitral valve replacement. So if the patient anatomy is suitable for all kind of things, and how do you tell the patient which patient that we are going to use the clip, which patient we are going to use the replacement, since
Sure.
there's many kind of data, and also the long term we still have to be like waiting for the long term outcome.
Yeah, that's a really good question, and it is. It's interesting because I actually submitted a proposal which got accepted for CTSN, looking at exactly kind of that. How, with all of these tools, what's the real world utilization of all of the transcatheter therapies for mitral valve disease? In other words, what percentile of patients over the last 10 years that are Medicare patients are receiving MitraClip versus TMVR in clinical trial versus surgical mitral valve replacement or repair. But to clinically answer that question, I think the first is understanding what their echo is. Because I think the decision point is initially, can this valve be repaired? Can we repair what God gave us and send the patient with what God gave to that patient? Or do we need to truly artificially put in some sort of valve replacement? And that is why I showed that 10-9 echo case, because that valve, if you recall, was so calcified, so degenerative, and already had baseline stenosis that a repair strategy wouldn't have been possible or good for the patient. So the first is understanding the echo and what are we trying to accomplish. If all things are considered equal, and if the patient falls into the guidelines for receiving a commercial repair device, that is generally what I offer the patient. If they don't fall into the commercial criteria of receiving a repair technology, then we take a look at clinical trial options like repair MR. And within the transcatheter edge-to-edge repair technology, we now have, of course, MitraClip, but we also had the Edwards-Pascal system, which was approved after the Class 2D results were presented at TCT for degenerative MR patients. And so when I try to decide between those two, I look at a few other echo characteristics, including what their starting mean mitral gradient is and what their leaflets look like.
So I'm going to ask a provocative question then. So if you have a patient who's repairable, because what I'm hearing is repair first. It's a repair first world. If replacement becomes super easy and just gets rid of the MR in about 20 minutes, do you think that that'll just eventually take over practice? Because it's kind of what we see in the surgical world, where it's just easier just to get in and out with complete relief with MR with replacement.
Yeah, I absolutely think that will be the case. And that's why I think that's why I put game-changing technology of the transeptal, transfemoral technology. Because you're right, I think that oftentimes the TEER procedures, you're in, you're out, you get a good result. But there is some variation in predictability that you can't 100% guarantee before starting any case, no matter how long you've been looking at the echoes beforehand. If we can adopt a more consistent procedure from a transfemoral venous approach, totally not transapical, to ensure that the device time and procedure time is acceptable and that we are truly always, for the most part, achieving a minimal MR, I think that in the future, we may no longer be doing TEER as much as we are doing right now. And interestingly, I think that just within the early tricuspid experience, we're already sort of seeing that. Anytime I saw a tricuspid TEER case scheduled on the cath lab, I would be like, oh my goodness. But anytime I saw a tricuspid TTVR, I was like, oh, this is great, because that procedure oftentimes took us an hour or so, and we knew we were going to walk away with minimal TR.
That's okay. You come see Travis.
we didn't have Paul at our institution.
Other questions?
We just had one final virtual question come through. The question is post-procedure cardiac rehab routinely ordered post-TAVR?
Yes, 100%. Absolutely. I would encourage that post, and even like I was talking about earlier, as prehab for frail patients.
It's part of our quality metrics. Well, we also want to thank Janssen Pharmaceuticals for sponsoring today's session, and I want to thank Dr. Sodhi again for a wonderful session this morning. And it's, again, welcome to Minneapolis. We'll take you coach shopping very soon.